Welcome to today's session. I think it's inaugural of this year's PG lecture series. Today's session is on the approach to anemias. There are different approaches to the problem of anemia. We're all familiar with the approach based on the size of the red cell, big cell, small cell, normal cell, the problems of production, the problems of blood loss and destruction, the inherited and the acquired, the nutritional anemias. But in today's talk, I would like to take a critical thinking approach to the problem of anemia. How is a knowledge of anemia appropriate to the context that we work in, the context of India? How do we relate anemias to geography, to tribe, to caste, to socioeconomic status, to the food? What is a cost-effective approach to the diagnosis and management of anemia? How do the policies and prevention strategies of the government address the issue of equity and access? And how should our approach to anemia be appropriate to the people, a people-oriented approach? Today's session will start off by a talk by Dr. Nandakumar Menon, who is my teacher, who is a senior consultant at the Goodlur Adivasi Hospital, an alumnus of CMC, a surgeon, but also an expert in sickle cell disease, to speak to a problem that he is familiar with. We also have, following Dr. Nandakumar, Mohan, who will discuss one of the cases that you have seen. I also want to thank Sukesh for joining us today to comment on the different presentations. I hand over to you, Nandakumar.
Thanks, Anand. Good afternoon, everyone. I'll be talking about basically focusing on anemia in sickle cell disease. And after the presentation, there'll be about 5 minutes for any questions that you have. So sickle cell disease is a global problem, and it has only been of recent attention in India. It was mostly considered to be an African disease, but we know that it's a global problem, and it was recognized as such in 2006, and 2008 is being a special day was being created for a sickle cell day. There are about 300,000 newborns with sickle cell disease born annually worldwide. I'm sure the number is much more because we haven't screened everyone in India. At least 50% of them are in Nigeria, Congo, and India. And 40,000 of this are born in India, which is 20 times the number born in the United States. India has the second highest burden of disease, at least 1 million. There's a recent article I read that said 20 million. So we really don't know how many patients we have with sickle cell disease, but it's a huge, huge number. And the prevalence of sickle cell carriers varies from different groups that have been studied across the country. Madhya Pradesh having the largest number. They have close to 70,000 sickle cell disease patients. So that's a distribution that you can see. In the old maps, it was all Africa, but today India has taken on a huge presence in the sickle cell disease scenario. Sickle cell disease in India among the tribals, we know that almost 10% of India's total population is tribal, which is like more than 100 million people. It's the largest number of tribals in the world. In our particular area, we have 6 tribal communities. And in our area, we've had the newborn screening, which is basically babies born in our hospital. We've been starting newborn screening using HPLC since 2011. We have close to 2,000 patients. And we have a 17% sickle cell trait. As you know, it's a recessive disease. So when you have one parent having the sickle gene, you have sickle cell trait, which is a benign condition. And we have 1% of our population, tribal population, having sickle cell disease. This is the screening data that we have for about 18,000 patients that we have screened, and of which the sickle cell trait is about 13%. And you can see here that the number of non-tribals, because we screened both the tribals as well as the non-tribals. We have a group of people called the Chettis in this area here, no connection with the Chettis in the plains of Tamil Nadu. And they actually have a higher percentage of sickle cell disease than the tribals. Now, this is not only present in the Nilgiris, but also in other areas like Dipti Jain has reported from Nagpur, where 92% of our patients are non-tribals. Rajiv Yadav in Jabalpur says 82% of his patients are. In our study, it's 57% non-tribals. So to say that sickle cell disease is a tribal disease is an error. Screening for sickle cell disease, sickle cell prep, where you use a film and you can see the sickle cells using a reducing agent like sodium beta bisulfite. The sickle solubility test, where you lyse the cells and the sickle hemoglobin being more like a precipitate makes the whole solution is as stable. This is electrophoresis, which is a very simple way of distinguishing sickle cell disease. The sickle hemoglobin has less of a negative charge compared to the normal hemoglobin, and so when you put them in blood in an electric field, you'll find that sickle hemoglobin moves slower than normal hemoglobin, and you can thus separate out the sickle hemoglobin from normal hemoglobin. Here you can see the control is a sickle cell trait patient, and you can see the second from the top has hemoglobin SS. The faint shadow that you see is hemoglobin F, a small amount of hemoglobin F being present. The point of care is a new way of quickly making a diagnosis of sickle cell disease. It only takes about 8 minutes, and it's based on the same cellulose acetase electrophoresis that I just showed you. It's an extremely sensitive and specific diagnosis, so it's a huge step forward where we can actually do the screening in the field itself. It comes to about 200 rupees per test, so it's a little bit more expensive than the other tests, but the great advantage is that you can get the diagnosis immediately. This is the kind of picture that James Herrick in 1910 must have seen when he looked at one of the patient's blood of a dental student with sickle cell disease, and it shows the typical anisocytosis, poikilocytosis, polychromasia, nucleated cells, and the sickle cells, which are characteristic of this disease. In sickle cell disease, there's a decreased deformity. The cells become less flexible as a result of the hemoglobin S being polymerized into inflexible rods and producing the sickle shape. These rods then have a difficult time going through the tortuous channels of the spleen, for example, and resulting in lysis. They also have an abnormal adherence. These cells adhere to the vascular endothelium, and this sets off a chain of reactions which eventually results in the formation of a clot and intravascular occlusion. There's an increased expression of adhesion molecules. The sickle hemoglobin only survives 1/10 of a normal hemoglobin survival, which is about 120 days. So it's about 10 to 14 days survival. So there's a tremendous production of red cells, continuous production and destruction of red cells taking place in sickle cell disease. The factors which precipitate sickling are hypoxia, cold, dehydration, infection, and stress. And these trigger off the process of the sickling process, resulting in hemolysis, both intravascular and extravascular hemolysis. And the debris causes occlusion, causes anemia as well as severe occlusion. And depending on the organ which is involved, if it's bone, which is the commonest, you get severe bone pain. If it's the brain, you get stroke and so on. Every single body system is affected by this occlusion. There's a picture showing how the red cells occlude the blood vessels. The normal hemoglobin in a sickle cell patient who is stable, who's not sick, and who comes to your OP is somewhere in the range of 7 to 9 grams %. So that's his normal baseline. There's no need to transfuse him to 10 or 14%. That's his normal hemoglobin. And this hemoglobin is important for us to know it because that's the kind of target that we use as his baseline. So post transfusion, we like to bring him back to his baseline. Now, the anemia in sickle cell disease is caused by multiple reasons. The most common being intravascular hemolysis, extravascular hemolysis. As we discussed, there's an abnormal red cell deformity. They can't deform. They're not flexible, and therefore they lyse. So we have intravascular hemolysis and causing intravascular occlusion, extravascular hemolysis because of the abnormal red cell, and also with exposure to certain chemicals. For example, in the spleen, they are broken down very easily. There's also a decreased production of erythropoietin. because of the destruction of the liver, of the kidney over a period of time. Multiple small infarcts as a result of intravascular occlusion causes the kidney to gradually deteriorate, and the production of erythropoietin decreases. There's also incomplete bone marrow compensation because of reduced erythropoietic activity and because of abnormal bone disease. The commonest reason for the patient coming to the hospital is bone pain. So there's constant destruction of bone taking place, bone infarcts, and sometimes leading to osteomyelitis. And often these vaso-occlusive crises are compounded by severe hemolysis and anemia. The anemia in sickle cell disease results in organ damage. As we know, anemia by itself increases cardiac output. There's cardiomegaly, left ventricular hypertrophy, dilated cardiomyopathy, and diastolic dysfunction. In the lungs, there's elevated pulmonary pressures leading to pulmonary hypertension. In the kidney, there's sickle nephropathy. Neurologically, there's an increase in the transcranial Doppler velocity. There's stroke. In many institutions, the Doppler velocity is recorded, and blood is actually transfused to decrease the anemia and the flow. And this has actually decreased the amount of stroke. In our population, stroke is uncommon. And so we have not, we don't do any transcranial Doppler studies and transfusion. There is a destruction of brain because of the cerebral vasculopathy and silent cerebral infarcts. In the bone, this is the commonest problem. The musculoskeletal system is infarcts, osteonecrosis, sometimes leading to osteomyelitis. There can be chronic skin ulcers, not so much in our situation, but in Africa. And there could be fractures as a result of osteoporosis. In general, anemia, as anemia anywhere else, would cause fatigue, weakness, disability, and health-related quality of life. The problem with the anemia here is, unlike anemia in other situations, this anemia is a chronic anemia. And we know that the anemia is causing poor oxygen delivery and organ failure and fatigue. But what is the optimal hemoglobin? Nobody really knows, because if you transfuse a patient to a high hemoglobin, there is an increase in the viscosity of blood, and the increased viscosity itself can trigger off vascular occlusion. So it's a fine balance between the anemia as well as to find out the optimal hemoglobin that's necessary to keep the person healthy. There's a lot of debate as to what is the optimal hemoglobin, but nobody is clear. And in our hospital, we try to bring the patient back to the baseline hemoglobin. So the ways by which you increase the hemoglobin would be blood transfusion, hydroxyurea, erythropoietin, and voxelotor. The last two we don't use. So as I said before, the chronic anemia in sickle cell disease usually has a baseline of 7 to 9%. They're generally mildly icteric in the normal situation. And on general examination, many of them, almost half of them, would have an enlarged spleen. And they have a typical facies, the sickle cell facies, as a result of the increased bone marrow size. They also have, they often also have gallstones and have complications with the gallstones. The sickling is actually precipitated by a number of factors like cold, hypoxia, dehydration, stress, psychological stress, anxiety. Any kind of change in their environment can precipitate a sickling attack. And so then this can result in a vaso-occlusive crisis with for example, a hemolytic crisis. This can give rise to an anemia, which is actually an acute anemia, which compounds the chronic anemia that sickle patients have. So there could be of three different types. It could be an sudden increase in hemolysis. There could be an aplastic crisis, or there could be a very unique situation called the acute splenic sequestration. In the hemolysis, there's a sudden increase as a result of the precipitating factors. There's a sudden increase in the rate of red cell destruction. So there's a drop in hemoglobin, there's increasing jaundice. So this has to be separated from gallstones causing obstruction. There's an increase in the reticulocyte count. And often the patient comes with other problems like infection or vaso-occlusive with severe pain, osteomyelitis, and so on. And as I said, we have to rule out the causes for jaundice, which could be gallbladder disease and hepatitis. The second is an infection caused by parvovirus B19. This causes a sudden fall in hemoglobin without an increase in jaundice. So the patient is not extremely jaundiced, looks the same, but his hemoglobin is dropping very rapidly because since the red cells, the red cell survival is only 10 to 14 days, the hemoglobin will go down to 0 in 2 weeks if nothing is done. So there's a temporary cessation of production of red cells as a result of the virus. And there's a decrease in the reticulocyte count, unlike in hemolysis where there's an increase. And this must be differentiated from a megaloblastic crisis. And a second episode of aplastic crisis is unusual. So as you can understand, the only thing we can do here is to give blood to bring back the hemoglobin. Otherwise, the patient would succumb. The sequestration crisis is a unique thing that we find in sickle cell disease. Here, in infants and young children, the spleen suddenly increases in size, and there's massive pooling of cells, causing a sudden drop in the blood volume, hypotension, and shock resulting. And this is responsible for almost 10 to 20% of deaths in the first 10 years of life. And in our hospital, it's been the second commonest cause of death. So the sequestration crisis is something which is an emergency. One cannot wait for even for the diagnosis. As soon as one sees the spleen is expanding, if the diagnosis of sickle cell disease is known, then you know right away that it's acute sequestration. And blood has to be transfused immediately. Very often the parents are taught the size of the spleen in children. So if the spleen is palpable, the mother is taught where the spleen ends. And if the child starts crying and then you palpate the abdomen and the spleen has increased in size, the child should be immediately brought to the hospital for transfusion. This is one of the common causes of death because there can be delay between the time the spleen expands in size and the infant or the child comes to the hospital. As you can see here, this is our mortality figures for between 2008 and 2018 when there were 22 mortalities, and severe anemia was the second commonest cause of death after the acute chest syndrome. We had a very unique experience here where we have no deaths between the age 0 to 5. This is considered in most reports from all over the world, especially Africa. Most deaths occur between 0 to 5. But in our case, it is all below the age between 20 and 30 years. So there is a difference in the mortality trend in different parts of the country. In ours, it is mostly young adults. 45% of deaths between 19 and 29 years, and 25% between 6 and 18 years. So acute chest syndrome, severe anemia, and sepsis. Acute chest syndrome is a result of occlusion of the pulmonary blood vessels. The patient has dyspnea. There's a fall in the oxygen saturation, and on chest X-ray there'll be a new infiltrate. So this patient that requires an exchange blood transfusion to bring down the hemoglobin, the sickle hemoglobin level, and it's a very serious condition, often resulting in death. So the treatment for acute on chronic sickle cell disease anemia would be treating the acute anemia with packed red cells. And the rule of thumb that we use is if the hemoglobin drops 2 grams below the baseline, then we transfuse them. And this there'll be multiple studies which indicate that there's improved neurological outcomes with transfusion for, as I mentioned before, in stroke, to prevent stroke, but we don't practice that. There's no need to transfuse a patient to the normal hemoglobin of 12 or 14 grams. That's absolutely unnecessary because the person will just have excessive hemolysis bringing him back down to the baseline. So avoid overtreatment. So that's our blood bank. We also have facilities for component separation for platelets. So the treatment of anemia and sickle cell disease is complex because we really don't know what level to transfuse them. In an emergent situation where the person has hypertension shock, obviously we need to transfuse them rapidly to bring the blood pressure back to normal. And again, as I said before, we try to reach the baseline levels of hemoglobin and look at the clinical parameters to see if the patient is hemodynamically stable. We also make sure that they have folate and B12. We avoid iron overload. In patients who have, the questions often asked, do you give iron to patients with sickle cell disease? And the answer, and our stand has been that if your patient has, for example, women in the childbearing age group who have not had blood transfusions, we give them iron tablets, just like the general population. However, if the person has had multiple transfusions, we avoid giving iron to prevent iron overload. Hydroxyurea, blood transfusion is needed. And as I said before, the ideal hemoglobin level is unclear. This is our protocol for the treatment for all sickle cell patients. From 0 to 2, we give them penicillin because their spleens do not produce opsonins, and they can succumb to infections from capsulated organisms like pneumococcus and meningococcus. If they are symptomatic, they're given hydroxyurea 10 milligrams. Above the age of 2, we administer pneumococcal vaccine 23, and then often we stop the pentates. We give folic acid and B12, and we administer hydroxyurea 10 milligrams per kilogram. The response is looked at by looking at the red cells. They often, if they become slightly larger in size, for example, then we know that they're taking their medications regularly. And also, there's a decrease in their anemia as well as their general well-being. If that doesn't happen, we increase the dose by 5 milligrams every 3 months to a maximum of 25 milligrams. Hydroxyurea still comes only as a 500 milligram capsule. So we have to open the capsule, take the powder, and divide it as needed for those who require less than 500 milligrams. Hydroxyurea increases the fetal hemoglobin, and fetal hemoglobin prevents polymerization of hemoglobin S. But it needs to have enough concentration within each red cell to prevent hemolysis. So they must contain a large amount of hemoglobin F, which survives much more than the hemoglobin SS. So increased hemoglobin F levels, so fetal hemoglobin, that's correlated with decreased mortality and painful episodes in patients with sickle cell disease. Hydroxyurea is a very safe drug. We've been using it for almost 15 years now, and it has very few patients who really have problems with it. The major problem being a decrease in the white cell count, in which case the dose is reduced and the patient is put back on a lower dose of hydroxyurea and then reassessed. Hydroxyurea has been a great step forward in the management of sickle cell patients, decreased their painful episodes, acute chest syndrome, and has also decreased transfusion since the hemoglobin levels are also protected by hydroxyurea. In addition to the medications, we need comprehensive care because many of our patients are in remote areas. So we have 8 area centers where these medicines are stocked, the vitamins and hydroxyurea, and they are looked at every month to make sure that they don't have any problems that could be treated. And this is an important component of sickle cell care. It's not just giving them hydroxyurea, but looking after them for their various illnesses to prevent the factors which precipitate sickling. Thank you. If there are any questions, I'll be happy to answer them.
If you have questions, come forward and ask. And Kay, why do you think strokes are so low in sickle cell disease in Goodloot? Why are strokes uncommon?
We really don't know. I mean, there are a few peculiar things in our cohort. One is that, as I said before, the deaths under the age of 5. There have been no deaths, we just had one death recently out of in all these years that we've been monitoring, and we've been doing newborn screening for the last 12 years. So that's something unusual. We've only had very few deaths that I can remember from stroke. It's a very uncommon thing. I don't know the reason why we don't do transcranial Doppler, although we're planning to start it because it's quite an invasive procedure trying to give blood every month. And we don't do any special testing other than the RH, the ABO factors. Again, we don't look at all the minor factors. So that's going to be a huge issue if we have monthly transfusions, as is recommended in stroke prophylaxis. From most big centers, sickle cell centers have monthly transfusion to keep up the hemoglobin and thus decrease the velocity. And that's been shown to decrease strokes. But because our stroke numbers are so low, we haven't got into it. So that's a totally and probably lead to iron overload, which has its own series of problems and treatments and necessary. So to give you a short answer, I don't know. It's only an observation that we have very low stroke rate.
So among the PGs, how many of you have taken care of any patient with a sickle cell disease? Just put up your hand. If you want to see sickle cell disease, you must go and visit Dr. Nandakumar. Nandakumar, you just want to tell them 2 or 3 lines about your hospital, because I think most of them don't know.
We are located in Sickle, which is a very, very beautiful part of the Nilgiris, about 50 kilometers between the Ooty and Mysore. And it's home to about 20,000 tribals who belong to 5 different tribal groups. The main group being the Paniyas, who are the who at one time were bonded laborers. These tribals have been displaced from the forest and had a very, very bad history of exploitation and basically, if you can say, of death because of their traditional way of life being totally disrupted, as well as being displaced. So it's not just displacement; it's also a destruction of their way of life. So it's a very difficult kind of situation to recover from. And so when we started the work in 86 and 87, when 2 doctors from CMC came there, the medical condition was abysmal. There was no antenatal checkup. There was 25% of patients had eclampsia. Infant mortality was 250. It was just unbelievable, the situation. And these people were dying for simple things like dysentery and dehydration. So the 2 doctors, Deva and Rupa, Devdas Narayan and Rupa, they're from the 79 batch, I think, CMC. Both are 79 batch CMC. They started training the health workers to start bringing the patients forward for immunization and antenatal care. And the work has always been with having the tribals themselves being taught how to take care of patients. So they started the whole process of training, and within a few years, they were so popular that patients wanted to be admitted. They wanted a hospital to look after the sick ones, and so Deva and Rupa wrote in desperation, were looking for doctors. And my wife, who was a gynecologist, and we joined, and we started the hospital. That was in 1990, and we trained the tribals as nurses, pharmacists, lab tech, and so on, sending them outside for training as well as in-house training. And over the years, we've now grown into a 50-bed hospital with all the facilities. We have a very good labor room, a good lab. We have 2 very, very modern operating rooms with laparoscopic facilities, a blood bank. So we're well-equipped 50-bed hospital at the present time. And we can do almost anything depending on the capacity of the doctors working here. So it's a secondary care hospital. Our referral rates are very low. We only refer out 10 or maybe at most 15% of our patients. So the secondary care hospital of this nature is of great importance, because the tribal patients don't want to go anywhere for treatment. They're afraid and they get lost when they go to a larger hospital. So they have been very keen on expanding the hospital so that they can also have opportunity for work as well as look after the larger non-tribal population. This has also had a massive impact on their self-esteem. They now have, since the hospital is owned by them, Ashwini is owned by the tribals. So this hospital belongs to the tribals. So it's something that is of great value to them. And as they look after the non-tribals as well, this has changed the dynamics in the relations between the tribals and the non-tribals in the population. So it has a huge impact on their self-esteem and has a very positive influence. So we we at the present time, we have a hospital with a very large community health program. So we cover 320 villages in an area about 50 by 50 kilometers. So it's all by the side of the Mudumalai sanctuary. We may have visited it, the tiger sanctuary. So we have these small hamlets distributed, and we have 8 area centers where we have public health nurses looking after the maybe about anywhere from 2,000 families. Sorry, 200. We totally have 5,000 families, so about 400 to 500 families per area center.
Thank you for joining us today, Nandakumar, and for sharing your experience and also showing us what all can be done in a secondary care hospital, addressing a local problem to a very high level of standard. I'm going to request Mohan to come and discuss his next case.
Thank you.
So we will discuss next case. Am I audible? So this is about a patient, a 52-year-old male, presented with acute onset abdominal pain, which was diffuse and squeezing type, with the intensity of 10 out of 10 on a rating scale. There was no history of abdominal distension, vomiting, or diarrhea. On clinical examination, there were no abnormal findings, except for mild tenderness. He was evaluated with ultrasound abdomen, CT abdomen, and upper GA scope, and the results are all normal. He is known to have diabetes mellitus type 2 for the past 2 years. He gives a history of taking indigenous medications for the control of diabetes prior to the onset of abdominal pain. So these are his lab results. Hemoglobin is 7.6, MCV is 77.4. These are his counts and platelets. Reticulocyte count is 7.6%. Iron and ferritin levels are here. LDH is 160, and total bilirubin, direct bilirubin levels are mentioned here. So the questions that we can take from this case is, how do you interpret these results? What is the likely cause of anemia? What are the next investigations that can be done, and how do you treat? Anyone can try to answer. Okay, we'll go to the next slide. So just to interpretation of the results, there is anemia, right? You all can agree. So you know the normal ranges of hemoglobin also, right? So accepted levels are more than 13 gram per deciliter for men, 11 gram per deciliter for women. So there is anemia here. And so if you look at the algorithmic approach to anemia according to the Harrisons, so patient has anemia here. Next step is you do the reticulocyte count. So we have a reticulocyte count that is available, which is 7.66%. So what is the normal level? 0.5 to 2.5%, right? So reticulocyte count. The next step is what? Index. Reticulocyte production index need to be calculated. So for this patient, after calculating production index, it is coming to 1.6. Can anyone tell me how to calculate reticulocyte production index? Just a formula. So hemoglobin, patient hemoglobin divided by normal hemoglobin. So 7.6 here divided by 15 multiplied by reticulocyte count that is given here. So that is the first step, right? You are correcting for the anemia. Second is what? Second step is you correct it for the lifespan of the RBCs, maturation, correct? Maturation index. So for his hematocrit and hemoglobin level, maturation factor, I have taken it as a 2.5 here. So it came to reticulocyte production index 1.6. So next step is here, reticulocyte production index is less than 2.5, correct? We are here at. So this is, then you look at the red cell morphology. So whether it is a normocytic or microcytic or macrocytic. So here we have his MCV value, that is 77.4, except it is above 80. So here it is. So he comes to this category, either micro or macrocytic. Here it is a microcytic. So you're with me, right? So patient has anemia. Next, look at reticulocyte count. Calculate reticulocyte production index by 2 steps. Look at the red cell morphology. Then you go to micro or macrocytic. Here patient is having probably microcytic anemia. So under this microcytic or macrocytic category, we have then 2 possibilities. It could be cytoplasmic defects or nuclear defects. So we have ruled out possible hemolysis or hemorrhage based on the reticulocyte production index. So we can rule out all these possible causes of anemia. And we have also ruled out hypoproliferative causes of anemia based on the morphology. Here MCV values are less than normal range. So that is why we are able to localize to possible these defects that are causing microcytic anemia. So if you look at 2 maturation defects, it is 2 types, either nuclear maturation defects, cytoplasmic maturation defects. So RBC has a nuclei and also cytoplasm, right? But once they are matured, there is no nucleus, correct? So in the process of production and maturation, the defects can be at either at the nucleus or at the cytoplasm. If the defects are at the nucleus, they have a characteristically macrocytosis. And the causes are vitamin B12 deficiency, folate deficiency, drugs like methotrexate, alcohol. Chronic alcoholism is associated with folate deficiency. So they can have macrocytosis. Myelodysplasia also can cause macrocytosis. But in our patient, vitamin B12, folic acid levels are normal. What about cytoplasmic maturation defects? So it is characterized by presence of microcytosis. So this patient MCV is 77.4. Hypochromia. So his MCH levels are 24.9. Cutoff is just 25 above. It is just at the lower side. And both will have nuclear maturation defects and cytoplasmic maturation defects have lower reticulocyte production index. That's what we calculated. Causes of cytoplasmic maturation defects are either severe iron deficiency anemia, thalassemia, or sideroblastic anemia. In this patient, iron, TIBC, ferritin levels are in the normal range. So we have ruled out iron deficiency anemia also. And thalassemia, there is no history of past history of any chronic blood transfusions. And sideroblastic anemia, we couldn't, unless we see the peripheral blood smear, we cannot diagnose. So let us look at the peripheral blood smear. So this is a peripheral blood smear report that is given by our clinical pathology department. So his peripheral blood smear contained anocytosis, hypochromia, polychromasia, coarse basophilic stippling, occasional spherocytosis, cystocytes only 0.4%, less than 1% is normal. And the comments they have given is rule out possibility of heavy metal poisoning in the peripheral blood smear. So then we went ahead and did his whole blood lead levels, which are very much elevated. So acceptable normal whole blood lead levels are less than 5 microgram per deciliter. His levels are very much elevated, 108.5. Other heavy metal levels, including mercury, arsenic, nickel, chromium, all are in normal range. So again, just to summarize, approaching anemia, if you follow this algorithm, you can you'll be able to point to one type of anemia. Here we have reached up to micro or macrocytic, and it could be probably cytoplasmic defects is what we were discussing. But however, it is not an iron deficiency anemia, or there is no thalassemia, and there are no sideroblasts on the peripheral blood smear. So it's a totally different peripheral blood smear picture that we were seeing here. And only one characteristic peripheral blood smear picture, peripheral blood smear finding that is suggestive of heavy metal poisoning they could tell is What do you think? Basophilic stippling. Okay, so based on this, they are saying possibility of heavy metal poisoning could be considered. But this basophilic stippling, do you think it is seen only in heavy metal poisoning, or it is seen in various other conditions? Can anyone tell any other causes of basophilic stippling? So it is seen in severe iron deficiency anemia, thalassemia, sickle cell anemia, sideroblastic anemia, chronic alcoholism, so various diseases it is seen, not just in lead poisoning. But presence of basophilic stippling along with elevated whole blood lead levels will lead to the diagnosis of possible lead poisoning causing severe anemia. So this is a peripheral blood smear picture. This I have taken from again from up to date. You can see here presence of basophilic stippling in RBCs. They are called punctate basophilia. They're like a punctate, small, which stain blue with the dyes. So that represents denatured RNA. So it contains ribosomes, RNA, and it stains negative for the iron. And this is a normal peripheral blood smear. And this is a patient with lead poisoning containing basophilic stippling. So this is our patients, the patient that we just discussed from our clinical pathology department. They have provided these slides. You can see here again the presence of basophilic stippling, and on low magnification you can again identify here the presence of basophilic stippling. So just to discuss how lead causes anemia, there are two mechanisms. The number one is it decreases hemoglobin synthesis, especially heme synthesis. Second is it can cause hemolysis. So related to heme synthesis, it inhibits several enzymes in heme biosynthetic pathway. So these are the various reactions that are involved in synthesis of heme, and lead is known to inhibit classically ALA dehydrase and ferrochelatase. So that leads to impaired heme synthesis and leading to anemia. So if there is a inhibition of ALA dehydrase, the precursors will be elevated, like delta amino levulinic acid, delta AL will be elevated. So that is another important finding that we could evaluate in this patient. His 24-hour urine delta AL levels were very much elevated, 66.4 milligram per 24 hours. Normal levels are less than 2.5 milligrams. And lead also causes defects in erythropoietin function, that is seen mostly in patients associated with kidney damage. So what about hemolysis? How does it cause hemolysis? So it causes hemolysis secondary to the shortened RBC lifespan due to the increased membrane fragility. This occurs due to the inhibition of two important enzymes in RBCs. The number one is lead directly can inhibit sodium potassium ATPase. We all know that sodium potassium ATPase is very, very important for cellular integrity. So not only RBCs, all the cells contain sodium potassium ATPase, so which is involved in extracellular transport of 3 sodiums out of the cell, whereas importing of 2 potassium into the cells. So that maintains the osmolality inside the cell, and also various transporters function is dependent on this enzyme. So whenever there is a inhibition of this enzyme, the osmolality will be affected. So there is a more and more water entry into the cells. So cell will swell up and it will lead to the lysis. Second mechanism how it causes hemolysis is inhibition of pyrimidine 5 nucleotidase. So if you look at this enzyme, which is very important in removing all the remnants of RNA from reticulocytes before they mature into mature RBCs. So like uridine monophosphates, cytidine monophosphates, they have to be dephosphorylated so that uridine cytidine will be formed, which will be taken away out of the cells. In that process, in the dephosphorylation, this enzyme is very, very important so that reticulocyte can become matured RBCs. So whenever there is a inhibition of this enzyme, so UMP and CMP and various other remnants of RNA will be precipitated inside the RBCs. That leads to the basophilic stippling. So this again leads to very premature release of RBCs into the circulation. Again, because of that leads to osmotic fragility and death of RBCs. So in summary, anemia has multi-factorial etiology. Heavy metal poisoning is one of the important causes of anemia. Severe lead poisoning causes anemia, which is moderate to severe. So the lead levels at which it can cause anemia is more than 40 milligram per deciliter. It can cause mild anemia, whereas more than 70 microgram per deciliter can cause severe anemia. So usually anemia that we have noticed in our patients is they are microcytic, hypochromic, with presence of characteristic basophilic stippling on peripheral blood smear. So the diagnosis of lead causing anemia is confirmed by elevated whole blood lead levels. In this patient also it's very much elevated. Investigations for presence of hemolysis and defects in heme synthesis should be done, that is elevated 24-hour delta ALA levels also, and other etiology like other biochemical investigations like LDH should be done, which will be elevated characteristically in patients with hemolysis. And management of patients with lead poisoning is identifying the source is very, very important, and removal of the source is very important. So in this patient, we have discussed in the beginning that patient was taking indigenous medications. So we have taken those indigenous medications, we have analyzed in our lab, which contained high amounts of lead. So based on which we have advised the patient to refrain from taking indigenous medication. And finally, we gave chelation therapy with disodium EDTA, and he is on follow-up now. His lead levels have come up and hemoglobin is slowly improving, and he is under follow-up. Thank you.
Can I use your slides?
Yes, sir. Please.
One question, sir. This is actually related to more of the pathogens of the blood picture. So RDW we say is for anisocytosis, and MCH will indicate the hypochromy. So what does polychromasia actually mean?
So that means different colors. So if you say hypochromia, I mean the red cell is having low color. But poly is usually red cell hemoglobin is stained eosin, that orange in color. So usually red cells appear orange. But if they appear slightly more bluish, it's because there's an acid which is taking the basic dye. That's a blue dye. RNA, reticulocyte contains RNA. So that's taking a little bit of the blue dye. So it appears bluish red. That's why it's called polychromy. So it's a good way to identify reticulocytes in the, otherwise you'll have to do a reticulocyte count. So just using, I'll take 2 more minutes. I'll just use his slides itself. So approach to anemia starts with hemoglobin, but hemoglobin doesn't get you anywhere. You need to have red cell indices. Now red cell indices, I think most commonly in India, everywhere it's possible from cell counters, but cell counters are not cheap. The cheapest cell counter is 2 lakhs, and the cost per test will be about 10 rupees. So, affordability for some people may not, but I think nowadays most of the setups, they have cell counters. Because you see, the easy way of getting cell counters is if you have number of patients coming to the hospital. If you're doing 10 or 20 counts per day, the company will keep it free of cost, because they only are interested in the 10 rupees from you. They'll make up the cost later on. But if you are having manual methods, I would avoid it, because quality control is very poor in manual method. Hemoglobin maybe, because there's a gold standard, we can do the Trapkins method. But doing Nabor counting chamber, red cell count, because you're counting only some 250 cells, you're multiplying it with depth factor and then making it million. So you can imagine how much error can come. So I would say that if cell counter is available, look at the cell counter data. If cell counter is not available, peripheral smear. That's the easiest approach to this thing. So now, for example, here, how many of you can appreciate the size of the red cell? Is it normal? Is it small? Is it large? It's very subjective, isn't it?
Small.
Huh? I don't know myself. If you give me the same slides tomorrow, I'll call it normal. If a day after tomorrow, I'll call it small red cell. But what is more objective is the color of the red cell. That is very clear. That's hypochromia. So and thing is, look at this. this will tell you that there is anisochromia. That means red cells are different color. It only happens if there is iron deficient erythropoiesis. So easiest way to identify iron deficient, I call it erythropoiesis because anemia will happen later. Whether the iron deficient erythropoiesis is because of anemia of chronic disease or because of iron deficiency. Anisochromia. One red cell will look more hypochromic, one red cell will look less hypochromic, but there will be hypochromia across. In thalassemia, even if it's thal major, you will not get anisochromia because that's coming from the same chrome. So the peripheral smear can give you a lot of information. So if you have a hypochromic red cell, you want to know whether this hypochromic red cell, because iron deficiency has happened, maybe the guy is taking medicines or not taking medicine. Now you want to know whether this hypochromic red cell, which is very badly hypochromic, happened 120 days back or happened 2 days back. If it happened 2 days back, then it's a bad story. If it happened 120 days back, then it's a good story. Probably he's recovering. So that is when you look at the polychromatophilic red cell, because that has only lifespan of 2 days. Those reticulocytes mature into the red cell. Then you look at the hemoglobin, the color of the polychromatophilic red cell. If it is hypochromic, that means the hypochromia has happened yesterday. If it is very nicely like some of the cells you saw, brightly blue and completely, there's no hypochromia, I mean, there's no central pallor at all. That means the hypochromic red cell that we saw must have happened 120 days back. So you can easily say whether the guy is having medicine or not having medicine. Of course, if anemia of chronic disease, you'll find both type of reticulocytes. You will have anisochromia in the reticulocytes also. So smear gives a lot of information. But if you have a cell counter, you cannot get anywhere in anemia without doing an MCD, RDW. RDW is useful, and reticulocyte count. Reticulocyte count, you can do it manually. But peripheral smear examination gives more information. So I think slowly digital morphology stages are coming up, but everything will be expensive. So yesterday I get a consult from Don Kurula. He sends me a picture like this from Robertsganj. He troubles me quite a lot. So he asked me one question: do you get hypochromic red cell and sickle cell anemia? So he sent me this picture. One ordinary microscope, he uses this camera through the eyepiece, he takes a picture. In fact, the picture he got today from our department is also taken like this, from this. So he sends me a picture and says that because there's a patient who underwent valve replacement, dropped hemoglobin. So with mechanical lysis, how to differentiate. So I said, identify hemoglobinuria. So hemoglobinuria, you don't have to spend too much money. Just do a dipstick. If it's positive for red cell, but you don't see red cells in the urine, then it's hemoglobin. So yeah, so he gets a lot of sickles in that case. Any questions? Yeah.
So the previous slide, this sickle cell usually study about autosplenectomy in the text.
Yeah.
But in Chinchpada, they have splenomegaly with screens of around 8 kilos. How do they explain?
So if thalassemia, especially if it's co-inherited with beta thalassemia, they'll have huge spleen. They don't have this sequestration crisis. They don't have the crisis that the vaso-occlusive crisis as much. But if they are not associated with, but usually they have massive spleens. In Chinchpada, there will be not much of alpha thalassemia. That's also cause of hypochromia among the. So in Orissa, sickle cells are associated with alpha thalassemia. But large spleen and sickle positivity is usually co-inheritance with beta thalassemia.
So we till now we've been discussing about sickle cell, about basophilic stippling and lead poisoning, and we'll discuss the first two cases which you've gone through. The first is an 80-year-old lady who's come with symptoms of anemia, had pallor, hyperpigmentation of the knuckles, fingertips, and palms, and had pancytopenia, hemoglobin of 5.5, macrocytic, with a WBC count of 3,000 and a platelet of 59,000. The blood smear showed macrocytosis, anisocytosis, and hypersegmented neutrophils. The second patient is a 20-year-old man who was working in an iron company, which was involving assembling automobiles, who came with pallor, jaundice, and on examination was in heart failure. Also had pancytopenia, had macrocytosis, had indirect hyperbilirubinemia, and had a similar blood smear. So the first question is, both these patients had low B12 levels. What is the cause of the megaloblastic anemia in the first case and in the second case? Answer? First case? Okay. Why are you saying it's pernicious anemia? Okay, so the diagnostic antibody is anti-intrinsic factor, but the sensitivity of this assay is only 60%. So this patient is an elderly person who's come to you and has got antibodies against the parietal cells, which has a sensitivity of about 100%, though a lower specificity. So overall, this patient has features like a pernicious anemia. Okay. What other clues would you look for pernicious anemia? What other autoimmune diseases are there with pernicious anemia? Diabetes, hypothyroidism, vitiligo, Addison's disease. All these, even hypothyroidism can occur associated with. So in this patient, what other tests would you do? The diagnosis of pernicious anemia. So what causes pernicious anemia? Autoimmune, atrophic gastritis, which is a risk factor for gastric carcinoma. So if you look to an endoscopy, what will you look for? Malignance. One is atrophic gastritis, and second is features of a carcinoid or a gastric malignancy. So this would be a situation where you would do a gastroscopy. Not all patients with vitamin B12 deficiency. In the second case, what is your diagnosis? What is different about this case? Okay, so why is this? Somebody said hemolytic anemia. Why did you say hemolytic anemia? Okay, so yeah, okay, but there is no reticulocytosis, right, in this patient. So this patient obviously has megaloblastic anemia, but has no overt signs of hemolysis. So what is happening? What is causing the indirect hyperbilirubinemia? It's a destruction of red cells, but in the marrow. There's ineffective erythropoiesis, and there's destruction of the red cells in the marrow, which is actually causing an indirect hyperbilirubinemia. So it's one situation where you actually have a production problem with the indirect hyperbilirubinemia, and you have a high LDH, which is also a feature of B12 deficiency and megaloblastic anemia. So this patient, what is the cause of the megaloblastic anemia? Why? Can this patient has megaloblastic anemia? Yes, it's due to vitamin B12 deficiency. Yes. So what are the causes of vitamin B12 deficiency? What are all the causes of vitamin B12 deficiency? Yes, the most common cause is dietary deficiency of vitamin B12. Okay. Now, so what other causes are there for vitamin B12 deficiency? Okay, so one is gastrectomy, so removal of the stomach. Then which part of the intestine? Ileum. So what are the diseases that affect the ileum? Tuberculosis and celiac disease. Okay, these are the common diseases. What drugs can cause megaloblastic anemia? Most commonly, metformin. What any other drug which you know of can cause megaloblastic anemia? So long-term proton pump inhibitors. If you're taking pantoprazole for a long time, you can develop megaloblastic anemia. Now, this patient did not have a gastrectomy, had no features of ileal disease, no history of chronic metformin use. So, what is the likely cause of megaloblastic anemia? Okay, so you asked him the history, was he a vegetarian? He said, no, but I take non-vegetarian food once a week. So what do you think? Is he taking adequate non-vegetarian food? No. So what will you do? So this patient is working for an iron company, but doesn't mean that he has a heavy metal poisoning. But you have a diagnosis clearly of a vitamin B12 deficiency, which is very likely to be due to lack of vitamin B12 in the diet. So how will you treat this patient? How will you treat this patient? This first patient did not have a bone marrow. What do you think? Needs a bone marrow or doesn't need a bone marrow? Doesn't. How many say you need a bone marrow? Okay, one. How many say you don't need a bone marrow? Okay, many people say because you're confident about your diagnosis. Okay, so in which situation will you actually do a bone marrow in this patient? Okay, so very good. So you want to give a trial of therapy and then see whether, so you want to give parenteral B12, injectable B12. Okay, how much B12? 500 micrograms IM. Okay, and when will you look for the reticulocyte response? No, within days, within 3 days, you should get a profound reticulocyte response, and the hemoglobin should start rising within 1 to 2 weeks and regain a normal hemoglobin within a month. Okay, so if this patient is you're giving injectable B12, you have a good reticulocytosis, hemoglobin is going up, then you don't need to do a bone marrow. So it's a very simple approach that you can use. Where you would do a bone marrow is where you're considering another diagnosis, like a leukemia or myelodysplastic syndrome, another cause of pancytopenia. So, so these two patients are different causes, right? So the second patient had a bone marrow, had megaloblastic anemia, and both patients responded well to therapy. So the second question is, what are the clinical clues when you see a patient for the presence of megaloblastic anemia? Hyperpigmentation. Where all? Knuckles and the creases. What else? What other features on examination you look for? In the mouth, what you're looking for? Glossitis. Okay. What else are you looking for? What history will you ask for? So what other organ is involved due to B12 deficiency? The central nervous system. So what symptoms will you ask for? Okay, neuropathy. What other symptoms? What other parts of the nervous system are affected? Classically produces the classical neurological syndrome. Subacute. So what are the symptoms? Okay, walking difficulty. Wash basin sign, difficulty in walking at night. Okay, and numbness. So what other neurological symptoms will you ask for? What are the other central nervous systems effects of B12 deficiency? Memory loss. What else? You can get a variety of neurological syndromes, from personality change to depression. Okay, you can get cerebellar involvement with ataxia. Okay, so any patient you are suspecting to have B12 deficiency, you must ask a neurological history, and do the relevant examination for findings of neuropathy and subacute combined degeneration. So in the clinical approach, so this is actually an article which was published in 1963. And this was published actually from the medicine department and Wellcome Labs. And the first author is an important figure. His name was Selwyn Baker. And this was published along with Mercy Ignatius, who was a research assistant, and Satyabama Johnson, who was a professor of medicine. Now, this was the first description of the association of B12 deficiency with megaloblastic anemia in the world. Okay, and this happened here, and this was only through careful clinical observation. And the clinical condition that was being evaluated was what? A condition we don't see now. It was a very common problem at that time, condition called tropical sprue. Okay, if you haven't heard about it, go read about it. To the cause of a chronic diarrhea with malabsorption of carbohydrate, fat, and protein, and B12 deficiency. So they were actually looking at this problem, and patients with tropical sprue came with macrocytic anemia. And the thing was how to prove that it is due to B12 deficiency. They did not have an assay to measure B12. So Dr. Baker established a B12 assay, which was based on a Euglena assay. It was not the standard biochemical test. For the first time in India, they established the B12 assay to show that patients actually had B12 deficiency. And in this description, they found 26 cases of tropical sprue with B12 deficiency associated with this characteristic hyperpigmentation over the creases, over the knuckles, and on treatment, the hyperpigmentation disappeared. And they showed that it did not occur with folate deficiency. And these patients did not have hypothyroidism. Okay, so this actually was a very important publication by people at your level, like a postgraduate was working with Dr. Selwyn Baker. So when we are evaluating a patient for a megaloblastic anemia, we need to ask for, very importantly, the dietary history. Look for pigmentation, glossitis, the CNS features, ask relevant drug history. We need to look for clues for pernicious anemia. And the next thing to do is to go to the lab and look under the blood smear, look at the red cell indices, and is there macrocytosis? And if there is macrocytosis, what is your differential diagnosis? What is the differential diagnosis of macrocytosis? Other than B12 deficiency? Alcohol, one more diagnosis. Hypothyroidism. Okay, these are the common causes of macrocytosis. You should order a B12 and folate level. Okay, and if your vitamin B12 is low and there is anemia or neurological features, you need to treat with parenteral B12. If a patient has no anemia and no neurological features and you just have a low B12, you can give oral B12 therapy as long as there is no malabsorption. What is the dose of oral B12 that you use? So in a patient who has pernicious anemia, can you use oral B12? Okay, so differing opinion. One person says no, one person says yes. So if you're giving high dose B12, how does it get absorbed if there's no intrinsic factor? By passive diffusion. So you're actually giving very high doses of B12 so that it actually gets absorbed because of water soluble vitamin. But nobody with severe megaloblastic anemia will actually treat with oral B12 because you're very worried. But the first case, this patient refused parenteral B12 and she had to be given oral B12. They monitored her and her hemoglobin came up and her B12 level normalized. So the first case actually shows that it is possible to give with oral B12, but in general, you would use only parenteral B12. Patient with B12 deficiency, do a pernicious anemia screen, and if it is positive, do a endoscopy. The folate is low, obviously you will give folate therapy, and bone marrow only if you are suspecting a diagnosis, an alternative diagnosis. Another point to remember is that the B12 assays, the normal is about 200, but 200 to 300 is borderline. Less than 200 is diagnostic of B12 deficiency. Remember that you can have megaloblastic anemia due to B12 even with a normal B12 level. So normal B12 does not rule out the presence of megaloblastic anemia. Now, if you're working in a mission hospital and there is no vitamin B12 or folate level, how will you manage a patient with megaloblastic anemia? How will you manage? Parenteral? Yeah, what will you give? If you got megaloblastic anemia, you don't know whether it's folate deficiency or B12 deficiency. Give both. Why? Why do you want to give both? What will happen if you give only folate? Okay, the neurological features may worsen. Okay, so in a patient, you're not able to establish what is the cause. It may be one or both. Okay, you administer both B12 and folate level in a situation where you can't. So in the days when I was doing my post-graduation, there was no assay. So we would do a bone marrow and then start on B12 and folic acid treatment. So the blood smear is important, and the characteristic findings are what we've discussed: macrocytosis, hypersegmented neutrophils, which have more than 5 lobes, right? Five lobes. Hubble-Jolly bodies, the teardrop cells, and varying size of the red cell, anisocytosis. So we all know what is the normal hemoglobin, but I want to ask the question, what is the normal hemoglobin and how is it defined? Now, these ones that you see, value of 13 for men, 12 for women, 11 for pregnant women, for children it varies. How is it defined? Who defined it? How would you, if you write an answer in your exam, what will you write? The definition of anemia. There is not adequate number of red cells who have adequate oxygen carrying capacity. That's what you would write. Now, it is defined by certain levels, but who defined it? So it's defined by the WHO. Now, the problem is that the WHO used 4 studies, which are often referenced, and all these studies were done in Western countries. Okay. Now, this is a publication which came out from St. John's Medical College by another well-known researcher, Dr. Aruna Kripad. And they looked at very large amount of Indian data of women, okay, of hemoglobin. And this is the graph, okay. Now, if you see that black line, that is 12. That is the normal hemoglobin in women. Now, all the women in this study which were healthy, most of them fell below 12. Okay. And when they looked at the 95%, you use confidence level, 2 confidence intervals, 2 standard deviations is 95%. They take the lower 5%, that value was 11.2. So in this publication, they suggested that the derived hemoglobin cutoff for the Indian population, the women, should not be 12, but it should be 11.2. Now, there are several other studies which have actually tried to look to say, is the value that is put forward by the WHO, what is a normal hemoglobin? And they come in different populations. It actually may be lower than the cutoffs that are stated. So there is a larger discussion of the need to redefine what is a normal hemoglobin, and the WHO is putting together a group which is looking at that, and maybe Sukesh can tell us more about that. Now, all of you have heard about the NFHS survey. NFHS, you know NFHS? National Family Health Survey. Okay, so this is NFHS data is used for a lot of things. It's also used to look at anemia, nutrition. Now, this is the data of the prevalence of anemia among women and children in the NFHS 4 and the NFHS 5, which are in 2014 to 15 and 19 to 21. Now, this was done for the prevalence for all women, adolescent women, pregnant women, and children. And what do we see in all of those? What's happening to the prevalence of anemia? It's increasing in all groups. Actually, the prevalence of anemia in women and children across a period of time of 5 to 6 years in our country is actually increasing. Now, this is the same data which is the NFHS survey on the left side, on the first 4 and 5 on the right side. And what you see here is that on the blue is all where the prevalence is more than 50%. Prevalence of anemia is more than 50%. And where do you find the blue in this on the left side? Okay, it's the colors are not projecting, but the main blues are starting with Andhra Pradesh, Telangana, going up to Orissa, Jharkhand, West Bengal, Bihar, Chhattisgarh, and going up to Assam, going on the right side, going on to Gujarat and to Ladakh. So we look at it geographically, the prevalence of anemia is high, particularly in certain parts of the country where a lot of our patients actually come from. Now, who are these women and children who are anemic? Now, this is another study which is again based on a very large data set in our country, which showed that people from scheduled caste and scheduled tribes are more prone to anemia. The economic status was a very dominant factor in whether the prevalence of anemia. It's the most dominant, even among scheduled castes, scheduled tribes, and OBCs. And anemia prevalence was highest among the poor and the most poor. And the odds of anemia were higher if you had less education, if you had more children. If we look at our country as a whole, the prevalence of anemia is very high. More than half the women in our country are anemic. And it varies in geography. And we also have to think, what is the social background of the problem of anemia? With that thing, we'll discuss the second case with a 40-year-old housewife from a low socioeconomic status. Go ahead.
Your previous second case also had concomitant iron deficiency. So he was also having complete nutrition deficiency.
The second case.
Yeah, this one.
Yeah.
Because if you see, he's got dimorphic blood, which are macrocyte and microcyte, and he's got some poikilocytes, which are classical of iron deficiency, like pencil-shaped cells.
The iron studies were normal, and the bone marrow also showed adequate iron.
Iron deficiency erythropoiesis in the form of some anemia of chronic disease or something, but there is the other thing is MCV is 99.4. Usually megaloblastic classically will be more than 120. But if you look at the RTW, most likely there will be. So the other thing is what we generally do is when we report the marrow, we also alert the physicians on the iron status. So if there is minimal iron stores, we alert, because when you start the treatment, the iron stores will get depleted in no time.
Okay.
The first set of reticulocytes would have taken all the iron.
So you need to look at the iron stores.
Whenever you look at a marrow report, look at the iron stores.
Sure.
If it's minimal or adequate. If it's minimal, then you have to replace iron. So
you think there was some other component also in this case, in addition to
some inflammation was there.
In addition to the okay.
And Selwyn Baker was a hematologist.
So everybody's trying. He's saying he's a hematologist, and he was so he's a physician. He was a hematologist also.
I think, his main interest was megaloblastic anemia when he was in Perth. So if you look at one publication, 1945, his name is there with megaloblastic anemia.
Is it? So he was a tough physician teacher. So if you were in the ward with Selwyn Baker, even if you are looking after 3 patients, you had to know all the patients in the ward because he asked anybody to present. So he was a very tough thing, but he was obviously a very fertile mind, and he looked at things quite critically.
The coagulation lab that I work in was started by him.
So originally Selwyn Baker was in medicine 1, and yes, and he's going to say he's in hematology. Though hematology didn't exist in that time, but actually he developed the interest in hematology, and medicine 1 developed interest in hematology through tropical sprue. And because of the work in tropical sprue, gastro split off and developed the gastroenterology department. And then later on, Dr. Pulnamur's interest in hematology led to Dr. Maman Chandy starting off the hematology department. But you can see that how problems and people sorting out problems lead to different interest area, which is really the spirit of this place.
Original letter from Robert McFarlane in Oxford, dated 1959, to Selwyn Baker on a coagulation issue.
Is it?
Robert McFarlane described the extensive pathways.
Okay. So you can see so many connections which are coming in today, which I didn't know about. So the second case is a 40-year-old lady who's come with retrosternal burning and tiredness, had anemia and koilonychia pallor, and your clinical diagnosis, iron deficiency anemia. It's got retrosternal burning. Okay, at acid type disease. Your interpretation of the hemogram, microcytic anemia. Okay, this is not the corrected retic, but it is low. There's a hypochromia, microcytosis, pencil-shaped cells, iron studies, low iron and high TIBIC, and ferritin is low. Okay, and so what tests in this case are needed to diagnose iron deficiency? If I didn't give you any tests, will you diagnose iron deficiency in this case? So koilonychia is a diagnostic sign. So you don't. So in this patient, if you don't need the hematological studies to diagnose iron deficiency anemia. So here in this patient, if you had a blood smear which showed hypochromia and microcytosis, you could initiate therapy straight away. But and if you did one biochemical test, what would that be? Ferritin level. It's the most sensitive biochemical measure of. So here, this patient had a whole lot of tests done, but actually we can focus on what is actually needed. And the stool occult blood was one test positive. So this patient underwent an endoscopy, and what was found? A esophageal web, okay, which was just below the cricoid, as a post-cricoid esophageal web. And when they went in and pulled the endoscope out, the web broke. And what do we call this syndrome? Plummer-Wilson, named after the 2 authors who describe the syndrome of the Plummer-Wilson syndrome, which occurs in severe iron deficiency anemia, and the cause of it is actually not very clear. So this patient, the classical symptoms of Plummer-Wilson syndrome, dysphagia. Okay, and what is the complication of Plummer-Wilson syndrome? Later you can develop a malignancy. It's a small rate, but that's it. But you don't have to do an endoscopy. You can actually do a barium swallow. This patient didn't have a barium swallow, but earlier we used to do a barium swallow to confirm and treat the iron deficiency with which the web disappears. Some patients may need dilatation. So the questions are, what is the least expensive way to diagnose iron deficiency anemia? The most important is the clinical, as we've discussed. And koilonychia is the most clinical test, the history, what is the diet of the patient, and the hemoglobin with a blood smear. Okay, that's a basic diagnosis. Hematological test, we look for microcytosis. So in a setting where you're clinically suspecting iron deficiency, the microcytic anemia, we've ruled out other causes of microcytosis, of thalassemia, of lead poisoning, okay, of sideroblastic anemia. They are unlikely. We can treat it as an iron deficiency anemia. And the only biochemical test that you really need to do is a ferritin level. So the iron and TIBC and the transferrin have a role in whether ferritin is normal. Okay, where you want to sort out, is it an anemia of chronic disease or is it an iron deficiency anemia? So this patient, the stool occult, which was blood which was positive. But remember that the stool occult blood sensitivity is only 70 to 80%. Okay. So the second question is, when should an endoscopy be done? So what is the Western guidelines for endoscopy for iron deficiency anemia? The UK guidelines? What is the guidelines?
Any patient above age 60 with severe anemia.
Okay, older age group with iron deficiency. What else? All men and postmenopausal women. Okay, so if we did endoscopies for all iron deficiency, we'll be not doing anything else. We'll only be doing endoscopies. So given the high prevalence of anemia, it doesn't make sense to do endoscopy on every patient. We really need to do endoscopy where we are suspecting a GI pathology. So we need to take a more conservative approach to the use of endoscopy. You see a lot of iron deficiency, a very prevalent problem, but not every patient with iron deficiency actually requires an endoscopy. So if they've got a very poor dietary history, you can give a trial of iron and see whether they respond. But if they have bowel symptoms of upper GI pathology or a lower GI pathology, an older age, a family history of cancer, and a higher index of suspicion in men and postmenopausal women. But trial of iron, and if they don't respond, is a suitable reason to go ahead for an endoscopy. So, what is the government doing about the problem of iron deficiency anemia? So there are food-based strategies, okay, which I'll talk about a little bit. Also iron. So who all should get iron according to the government? Who all should get iron? Okay. Sorry, say that loudly. Children, some more. And all women and adolescent girls. So this is actually from the iron deficiency, the manual of the government, that all these four groups need to get iron. Okay, pregnant and lactating women, women of reproductive age, adolescent girls, and children all should get iron therapy. Now, Dr. Maman Chandi, he's an expert, right? He's a hematologist. So he was asked by the government of India to go and evaluate the treatment of anemia, the government program. And he said that he went all over the place, talked to many, and he found that there was a lot of women who had iron, but they were not taking it. So what is the problem of iron supplementation? So what is the biggest problem? Yeah, that it's intolerance to iron. It's not a pleasant drug to take. Okay, so you can get gastritis, get vomiting, it kills the appetite, the metallic taste in the tongue. Okay, all these are the side effects of iron therapy. So people don't like to take iron therapy. So this was a qualitative study in Orissa to look at why iron does not work. And what they found is that women underestimate whether anemia is there. There's a belief that if you take iron, you'll have a big baby. If you have a big baby, you'll have obstetric problems. Mother-in-laws don't allow women to take iron. Pregnant women and adolescents were taking iron, but not all women. And health workers think that iron should be given only to the pregnant and lactating women. But there are a lot of reasons why people, though iron is being administered in the government as a program, it's not working very well. But is it only a problem that the program is not working well? Now, this is data from the NFHS 4 and 5 of the nutritional status in children. And what do we see in this? Between NFHS 4 and 5, the data that I've told you, right? That the percentage of anemia. What else are you seeing in this survey? What has happened to stunting, wasting, severe wasting? What are you seeing? Has it come down? Has it come down significantly? Okay, so it shows that across the country, 7% of children under 5 are severely wasted. Why is that? Why is it that the percentage of wasting is overall 19%? Why is it? Why are children wasted? Lack of malnutrition due to lack of okay. The NFHS data actually shows that the problem of lack of food. Now, when you look at the same data of severe wasting among children under 5, what do you see about this map and the earlier map I showed you? Are there similarities? The blue. Okay, we see Orissa, Jharkhand, Bihar, MP, and you look here, this is the light blue is 6% wasting. Okay, so quite significant. But we see a lot of overlap between the states which have high percentage of anemia and high percentage of wasting. Okay, and it tells us something, that the problem of anemia that we're seeing, we want to say it's iron deficiency, but it's actually a problem of food. Okay. And the problem that we are seeing today of the clinical problem is also a problem of lack of food, but in a very much larger scale in the country. So the government is trying to implement the iron deficiency program management, but the problem is actually lack of food. And if we look at the budgetary allocation in the current year's budget for women and child development to the program, what we see over a period of 10 years, what has been the budgetary allocation? It is coming down. Okay, it's actually decreasing, and these support feeding programs for women and children. The national guidelines for control are advocating dietary therapies of which are predominant. All the pictures here are what? Vegetarian food. But what is better if you want to replace iron? Vegetarian or non-vegetarian? Huh? It's better to eat meat or it's better to eat vegetables to improve your iron? It's more easily, it's ferrous, which is easily absorbable. Okay, so non-vegetarian food have easily absorbable iron. And the government is also advocating strategies like fortification of rice with iron, which is quite controversial. So the question I want to leave you with, and I'm going to conclude at this point, we can't think of anemia as some knowledge from somewhere else, which we are applying here. We have to think about anemia for our current context. Where is the anemia geographically? Who is affected by anemia according to scheduled caste, scheduled tribe? How does poverty link up with the problem of anemia? And we need to tailor are approaches to the clinical, the history, the physical examination, the use of basic tests to make a diagnosis, a cost-effective approach to the management, and not only prescribe but also look at the social context of the food, particularly the diet. So we need a contextual approach to the problem of anemia, which is addressing with deprivation, which is at the heart of the problem.
I have a question about that. I mean, food supplementation and all has actually improved to a certain extent, at least, I mean, over the past 5 years or so. There is a lot of strides towards it. So is it that the population has increased and so the statistics are still showing? Because I can still understand if it's the same or the same. It's actually increasing.
And we take Sukesh's view. He's
in terms of stunting, in terms of wasting, not just the iron deficiency.
So what is the food supplementation being given?
I mean, now I'm just saying that we would expect that over 5 years or so, the PDS system would have been better, distribution would have improved, something would have happened, or if nothing else, at least somebody would have taken the iron that was given to them. Why is it increasing is my question. If it remains the same or stagnant, we can say it's not having much impact. But increasing, is there some other factor which you're missing?
I don't know.
I mean, non-compliance is very high. Like, I don't know whether some of you work in Chittoor, I used to send comments, iron deficient erythropoiesis is not compliant to therapy for anemia. Then I get calls from obstetrician. She said she's taking the tablet. I said, no, she's not taking the tablet. I can easily make it out from the peripheral.
It's a question you have to think about, because this is government data. It's not anybody else. It's the government's own data, just showing an increasing prevalence of iron deficiency. So it obviously means that whatever is being done is not adequate, right? And on the one hand, the government is actually trying to show that poverty is coming down, but we're actually seeing that anemia is increasing. And so Dr. Ramanamma, who's a community health specialist and worked across many areas in tribal areas in the country, she came and she was actually showing us the data on the malnutrition in children, and that the targets were not being achieved. And that was because the feeding programs were not properly invested in. So if you go to tribal areas, there's actually scarcity of food, which is a real problem. And people who work in tribal areas will know it. So it definitely, food is a real problem. And I think what our data is actually showing us that it's not just iron supplementation, but it's a diversity of food that is actually important.
But the sporting issues, like, is it that they're picking up more now? Because again, the point is that it's increasing, which should not be the case. I mean, some healthcare would have improved, some supplementation would have improved. If it's stagnant, also, why should it increase over time? So is it a population, or is it that we're picking up more anemia now because more people are coming?
I'm unable to comment on that. Yeah.
Iron deficiency would be 30 to 40% of the cause of anemia here. So probably there could be programs which are picking up other forms of anemias.
I have two doubts regarding treatment of iron deficiency. Patient presenting severe iron deficiency anemia, let's say actually less than 5. Is it okay to treat the patient with oral iron alone, or giving IV iron would be better in improving actually? Provided the compliance is good, patient is not having dyspepsia kind of thing with oral iron. And the second question would be, is there anything like alternate day of iron therapy would be better when compared to daily iron therapy regarding absorption and bioavailability?
Okay, I'll give you both my answers to the question. The first is the treatment is determined by the clinical status of the patient. So obviously, if a person is anemic and in heart failure with hemoglobin of 5, you have to transfuse. You don't have any other option. Okay, if you don't have transfusions or you don't want to expose a person to transfusion therapy, parenteral iron is a quick way to ensure that you replenish the iron. The oral iron therapy does take time. But I have managed patients with 5 gram hemoglobin with iron therapy, and the hemoglobin has gone up. So it depends really on the clinical status. But if you start on iron therapy, you have to follow up and make sure that there is reticulocytosis and the hemoglobin is going up. Monitor the hemoglobin. So it depends entirely on the clinical status. We're using parenteral iron much more right now in different settings. Patients who are very severe anemia, I don't use parenteral iron therapy. The antenatal program in the country is now using parenteral iron therapy particularly for hemoglobins of 6 to 8. They're lower than 6, they need transfusion, but otherwise, so parenteral iron is quite safe. You're not so worried about allergy. And if you look at the overall cost for oral iron together, it may come to about the same. The second question was about oral iron. So tolerance is a big issue. There is data showing that alternate day and daily have about the same effect, but I have not used alternate day therapy. If a person is intolerant of iron, what can you do? So you can give alternate day therapies. One, give iron with food, give an iron with milk, though it will reduce absorption, or give iron with proton pump inhibitors. All these are things that you can do. Whether the plain iron given by the government has more intolerance than if you give, say, Fefol or you give Livogen, I don't know. I don't have any personal experience. Some people prefer the preparations which are bought rather than the government. So these are my answers.
So I have actually, oral iron, quite magical. Because next day I can see a response in the reticulocyte. Even the reticulocyte count also goes up. And the quality of the reticulocytes up. But of course, one tablet is not going to do much. But the effect is seen immediately. That's one. Second thing is, we wanted to start iron replacement for blood donors because they can get depleted of iron. So we consulted data from a recent study that biochemistry had conducted from 1 year. They found that alternate iron was not good compared to daily, but daily once a day. They found that they prefer daily iron rather than daily. The data will be published.
So one more regarding formulation, we have Livogen and Artrin. Which would be
I don't know. Most of the data don't show any difference in absorption between preparations. So all proprietary preparations, and any form of iron, the citrate formation, all the formations have about equal absorption. So did you look at the other case? One case. You remember this case? What's your diagnosis? What's the case? A 20-year-old laborer from Kadapa who developed fever and abdominal pain. Diagnosed of malaria, given Primaquine. And what happened? Okay, so this is G6PD. What are you seeing in this? What's happened to the serum? It's red, right? And the urine is black. And they've done the hemoglobin tests in the urine, which are positive, and the serum also are positive. So the phenomenon that you're seeing here is intravascular hemolysis. What's the differential diagnosis of intravascular hemolysis? Some more diagnosis. What all causes intravascular hemolysis? Can sickle produce intravascular hemolysis? Not common, but can. Then more common. Okay, very severe autoimmune hemolytic anemia can be associated with intravascular hemolysis. What else? Something which you have not seen is a transfusion mismatch. Transfusion mismatch can cause severe intravascular hemolysis. Prosthetic valves can give, yeah. In the earlier days, they used to, when the prosthetic surgery, they use distilled water to wash out the bladder. Distilled water goes into the blood, it can cause intravascular hemolysis. There are various different causes, but here this patient actually has taken primaquine, right, which is the most common drug which causes G6PD induced hemolysis. And what complication has the patient developed due to the intravascular hemolysis? What's under creatinine? Developed a renal failure, okay, an acute kidney injury. So this is the blood smear on this patient. This blood smear of this patient actually showed ghost cells. There were red cells which were broken and they were empty. There was no hemoglobin inside. And they also showed Heinz bodies, okay, which were within the red cell. So how will you manage this patient? The patient who's been exposed to primaquine has come with a severe intravascular hemolysis. Yeah, the most important is stop the inciting drug. Then management of the anemia, Paxil transfusion. Then what are you worried about? All the pigment is going in, clogging up the kidney. So what do you want to do? Hydration. You can alkalinize the urine. If the patient is in renal failure, they may need hemodialysis or a conservative management for the renal failure. And these are the basic principles of management. Okay. Now this patient actually had an appendicitis and was wrongly diagnosed to have malaria. So here we were actually managing a patient who had appendicitis, who went into acute renal failure due to intravascular hemolysis. And so we had to dialyze, it managed in the ICU, and fortunately he came out. Okay. So when will you do the G6PD assay in this patient? It's very important. Don't do it at the time of the hemolysis. Wait for the normal red cells to form and then check the G6PD. And what patient education will you do? What's the important things? You need to give a drug list. Okay, and you also, what else can cause hemolysis in a G6PD patient who has G6PD deficiency? Foods. What foods in the Indian diet can cause hemolysis? Other beans, so legumes of different kinds can actually cause. There are also foods with artificial preservatives. They can induce a G6PD. So you should avoid foods which have other preservatives inside them. Infections can cause a G6PD hemolysis. So you need to alert patients. So I had one patient who came recently with a boy from Assam. And he came, and so we had to put a lot of education, give him the full drug list, and tell him how to identify when he's going through hemolysis, to go to the hospital quickly, withdraw the drugs, take transfusions. So these are all things that you need to do when you have a patient who has a G6PD deficiency. These are all the common drugs, and you need to go through patient education.
You can get oxidant hemolysis. The hemolysis that happens in G6PD is called oxidant hemolysis. When the hemoglobin is getting oxidized and they become denatured. That's how they form antibodies. So you can get oxidant hemolysis even with normal G6PD levels. Some drugs like metformin is very famous for, but they won't cause hemolysis
like this.
But you can get oxidant hemolysis with in normal people. And the reason it's called cola colored urine is because it's a dark colored urine with a white froth.
Oh,
Cola has
like Coca-Cola. Okay.
If you have a dark colored urine with a dark colored froth, then it's obstructive jaundice because the surface tension has come down and the color of the urine passes into the froth.
Okay, so the dark colored froth, it's a jaundice.
Severe obstructive jaundice.
Okay. And in the one with the hemoglobinuria?
Will be white froth.
White colored froth. Okay. And I didn't know that.
And if suppose it's a red colored urine, but it's transparent, while hematuria will be a red smoky urine. Very smoky. So that's hematuria, while this is hemoglobin.
Okay. It's very important to actually make out these distinctions. And so if you have dark urine and there are no red cells, you have to think of all these differential diagnoses of hemoglobinuria and also jaundice. That's quite obvious when the patient is jaundiced. So this patient was really tough to manage, and but it was quite an experience. But you will encounter G6PD deficiency at different points in your life. So